thank you very much for joining us this afternoon for another one of our health policy lectures. We're so pleased today to have a very special visitor with us, Mr. John Deane. John was formerly on the staff here at UTMB as the Executive Director of UT Med. Sitting behind him is Dr. Mike Warren, another one of those former executive directors of UT Med and the prison, everything else. So thank you for being here, both of you gentlemen. We're going to not let Mike talk, John, just you, okay? It'll be hard to do. These lectures are brought to you by the Office of the President and the Office for Health Policy and Legislative Affairs. We also have the privilege of sponsorship of these with the student TMA AMA group. Vanessa Collins is their president, and Matthew LaCour is the vice president. Would y'all stand up, be recognized? They hustle out their fellow students to these events. I'd like to thank all of our students for attending, whether you're in a graduate school or the medical school or our nursing, PA, whatever. Thank you for being here. I also want to thank our chairman for supporting this event today. Today, John Deane comes to us with over 24 years of senior health management experience working at the intersection between hospitals and physician and creating that relationship. He has literally seen medicine happen in the United States. From practicing at this academic center where he helped us successfully launch a real faculty group practice and our clinics into the community in a competitive practice of medicine, to his time working with FICOR and other physician groups launching their businesses, to being the founding and managing partner of Southwind Health Partners, major consulting firm, and now being affiliated with the advisory board in a consulting capacity and leading their think tank on what's happening in healthcare in the future. The advisory board is a research, technology, and consulting firm specializing in performance improvement, and the company partners with over 230,000 leaders in 5,200 organizations throughout healthcare to focus on education and developing the best of quality practice for physicians, healthcare providers, and patients. John holds a Bachelor of Science degree in Political Sciences and a Master's in Public Administration from the American University in Washington, D.C. He's been a featured speaker for a number of professional organizations, but you will see him frequently on the agenda at the Medical Group Management Association meetings, the American Hospital Association meetings, the Association of American Medical Colleges, and numerous others. He founded Southwind and served as Vice President of Operations for a national physicians management company. He's also spent a lot of time working in both the South United States and the Northern United States. On another occasion, he'll let him tell you about taking his family and cruising the South Winds off Australia and some exciting things like that. He has led a most adventuresome life, but I can't think of anything more adventuresome than riding the waves and tides that are ever changing in healthcare. John has volunteered his time today, so for that we at UTMB are even more grateful that his knowledge is imparted without a fee today. Nevertheless, we can always impose on old friendships, right, Dr. Warren? John Deane, please enlighten us about delivering value-based health care in this consumer-focused world. And please don't discourage the medical students that are here and have them drop out, okay?
Thank you very much. Well, I can't tell you what a thrill it is to be here in Levin Hall, of all places, to meet with what would have been my colleagues, and some of you actually were my colleagues when I was here in the late 80s and early 90s. I had the opportunity to be a part of management here at a very young age in a key role. And I just want to be perfectly clear that if there's anything about the talk today that you don't like, it's entirely Mike Warren's fault. because Mike led a team with Jerry Peterson and Jim Ahrens to come to St. Louis to visit me when I was working at Washington University Medical Center. I was running the physician hospital organization that was the first time that Barnes Hospital, Jewish Hospital, and St. Louis Children's Hospital joined together with the School of Medicine and hired a person. I was paid 25% by each. And the chairman of the board of this physician hospital organization was Dr. Neville Grant. And Dr. Grant was the preeminent internist on the staff at Washington University. He was a private practicing physician working out of a small practice of colleagues that was started by his father, Sam Grant, and he worked with his brother, Jack Grant, all amazing men. And it was my privilege to sit with him in his basement on Saturday mornings where we planned and plotted. We developed a health maintenance organization that was funded by the university, Barnes Jewish and Children's. We developed a single point of managed care contracting. About the third weekend in, he said, "This week, when you come over, John, I want to take you to lunch afterwards with my wife, Diane." I said, "That'll be lovely." So I came in, met Diane before the meeting started. She and I exchanged pleasantries. I went down in the basement with Dr. Grant. Diane went up into her bedroom upstairs and called her daughter, Natasha, and said, "Natasha, you are having lunch with your father today." And so we came up out of the basement. Diane Grant was nowhere to be found, but here was Natasha and Dr. Grant taking me to lunch. Natasha is here today as my wife. Give her a round of applause. Now I became a little bit famous when I arrived at UTMB because I was the new kid on the block and we were doing cool things and Mike Warren was in charge. And so that meant, that it was a really happening thing. But when Natasha was awarded the Howard Hughes Pre-Doctoral Fellowship for the first time at UTMB, I believe, I became Natasha's husband. And I was privileged to share our experience together over the last 26, soon to be 27 years. And so everything that I have achieved has really been in partnership with her. And Natasha, I'm thrilled that you could be here today to celebrate our time at UTMB. I was also here at a very interesting time in the life of TDCJ. The bracketed lines was the time period when I was here, and I had been doing managed care contracting at WashU, and we were embarking on setting up the network inclusive of St. Mary's Hospital and the community physicians back then. But the TDCJ came knocking on the door, of course Mike Warren's door I think it was, and said, we are expanding. We're going to grow from 39,000 prisoners to 150,000 prisoners in the next 5 years, and we need to develop a healthcare delivery system that expands way beyond UTMB. And so you can see this happening here. And it was a big part of what we thought of at the time as huge success because we had been taking care of the prisoners, the faculty physicians, I say we, the doctors had been taking care of the prisoners for no reimbursement. It's kind of like my talk here today. We were just sort of stepping up because it was great clinical pathology, good teaching material, and the right thing to do. And now the prison system wanted to pay doctors in the free world for their services at market rates, and they wanted us to arrange it. So we said, great, we'll do that. But there's one little thing. If we're going to pay doctors for their services in the free world, we need to be paid too. And that represented an opportunity for UTMB measured in about $20 million a year in annual new revenue, which made Mike and I look like heroes. But I had to explain all this to my adult daughters. And they've been reading this book called The New Jim Crow by Michelle Alexander, and they become social activists in their young adult life. And they said, "Dad, you were part of a whole system that was designed to dramatically increase the incarceration of minorities." And so we are having continuing talks in our family about this issue. And my only comment about it is it will be interesting to see what does happen with incarceration in Texas over the next 20 years. Given everything we're seeing and hearing in the public sphere about the use of prisons. But it was an amazing experience, and as I said, a big part of our success. I'm looking to press forward here. Here we go. Now we've got this election going on, and a lot of people ask me, they say, what does it mean? If we vote for a Democrat, or if we vote for Bernie or Hillary, or if we vote for a Republican, what's it going to mean to the healthcare system? And they all have different points of view. Bernie wants to go much further with Medicare for all. Hillary wants to, saddle up with President Obama and tweak Obamacare and make it better. And the Republicans want to repeal and replace. I don't want to talk about that because I'm not sure how that's going to go. I'm sure it will be important. I'm sure it will be meaningful in terms of how our future is affected as healthcare. I want to talk about what I know is going to happen and what we need to plan for no matter who we elect, because I think that's more instructive. If I can get it to turn. Maybe. Must be doing something wrong. Point at where? Oh, there we go. That's the answer. Pointed at the podium. So we've got three big things going on here in terms of where healthcare is going beyond the political question, and huge pressures coming down, as you know. We've got the government, which is, for most institutions, the vast majority of the business. We have employers and consumers. And what's happening is that risk is coming. We're all having these conversations about the transition from volume to value. And a lot of these conversations are flavored in the notion that we actually have a choice about whether or not we're going to make that journey and when we're going to make it. Well, I'm kind of here to tell you it's happening now. And I want to unpack that a little bit. But we see Medicare doubling down on risk. Medicare Advantage, which was a program that at one point in time we thought was doomed, is now taking off like a rocket. And we see Medicaid increasingly getting into risk and engaging with consumers. Employers are relying on the private exchanges, and that's increasing pricing pressure for us. Self-insured employers focusing on utilization control. We'll talk a little bit about that. But a big trend that we're seeing is that consumers are actually having to pay out of pocket for a big chunk of what it is they receive in healthcare services. And that's going to change our world because for most of my career, and I dare say many of you, the deal is that insurance would take care of it, and healthcare was kind of an entitlement for the insured. And, you were lucky that we could take care of you, and whether it was a nice experience or not was really beside the point. Well, that's going to change. So what's going on with Medicare, CMS? Well, there are aggressive targets that are shifting toward risk. Here we see from the advisory board from last year, 20% of Medicare payments tied to risk models. It's going to 50% in 2018. And a 50% increase from 20 to 30% in this year. If we're in the fee-for-service world, we're still seeing tremendous shift toward risk because we're having to earn our fee-for-service payments by demonstrating quality and adherence to metrics. And so that's a form of risk that we need to embrace if we're going to be financially successful. I want to unpack those a little bit. Maybe. There we go. So there's risk opportunities. You can sign up, and then there's mandatory risk. And so let's talk about mandatory risk. So after accounting for penalties and bonuses that the Medicare program has developed, what we're seeing is that the impact on hospitals has not been great. 28% of hospitals got a bonus or broke even last year. 50% received net penalties between 0 and 1%. So they're kind of breaking even, but it's on the negative side of breaking even. And 6.5% received penalties of 2% or greater. And this is not for signing up or anything. This is just living with the new rules of how our government is paying us to do what we do. Merit-based incentive system, MIPS. Everybody in here heard of MIPS? raise your hand if you've heard of MIPS. I want to get a sense of how widely understood this is. This is the physician fee schedule methodology that incorporates the EHR incentive, the PQRS, the Physician Quality Reporting System, and value-based payment modifier all into one. And when we look at where we're headed with MIPS, we can see that our physician payments by 2022 are going to be at risk to the tune of 9%. So that's new. As an alternative to that, they've created this program called the Alternative Payment Models, where there's risk and bonuses in play. And this is a choice that can take you out of the MIPS system. But we also have another choice, which is Medicare Advantage, I'll talk about in a minute. Bundled payments, very interesting development in the last few months. Comprehensive care for joint replacements, we are seeing orthopedic bundling required by Medicare in 67 markets. This is not one of them, but in 67 markets around the country, over 200 hospitals, it's not an option. It is what is happening. The government is, what is bundled payments? We're setting a price. We're saying this is what we'll pay, figure it out. Anesthesia, pre-hospitalization, post-operative, post-acute care, all of that. This will be expanded, and the initial focus is on joints. It's comprehensive for 90 days post-discharge, mandatory in 67 markets, and it'll go past that. See, the new law basically allows the Secretary of HHS to lead experiments and initiatives, and when they go well, replicate them without having to pass another law. And so that's huge, because in the past, every time we wanted to make any change in how we were paid by government, the legislature, Congress, would be involved in that decision. But now Congress has said, you know what, if it works, just go do it. And what they're finding is the pilot studies are becoming this kind of program, and then they get expanded to everybody. Shared savings. So the notion is, let's form an accountable care organization, kind of like the PHO or PHOs of the past, and we'll organize the doctors. We'll do retrospective attribution. So we won't tell you who the patients are ahead of time, but we'll look back to adjudicate that. That's a problem, but they're working through that. And the notion is we're on a budget, and if we do better, we can share in those savings. And depending on your appetite for risk, and this is a choice, the ACO can sign up for more risk reward or less, maybe even no downside. So how's that going? How's that working out? Well, 187 early ACOs renewed participation in this year. 100 are joining for the first time. So the appetite for institutions across America to do this work is increasing. We have a whole department of our firm that does nothing but help institutions submit their applications to CMS to become an ACO. 22 of those ACOs are accepting downside risk. So most people are getting in, but they're getting in for a small bonus, not for the opportunity to do better than that in return for downside risk. But it is happening. It's interesting when you do the math, though. For the country, it's not working out so hot. So in this cohort of institutions that have been doing this work, $806 million has been saved from 92 successful ACOs. Congratulations. Savings from 89 ACOs that save the government money, but not enough to earn a bonus, because you have to save above a threshold to get the bonus. That was another $168 million. We call that the free rider, right? The government got the benefit, didn't have to share back. Losses from the ACOs who spent above benchmarks were huge, $683 million. So we're clearly still learning how to do this work, take care of a population, at least looking at the attribution retrospectively. So that leaves us to 291 net savings, or gross savings, they call it here, from these ACOs. And then they got to pay out bonuses to doctors and hospitals to the next generation ACO model. So what is that? Well, on the financial model, prospective benchmark using a one-year baseline, trended forward using regional factors, beat that, and we'll share back 80 to 85%, right? All of a sudden, that's going to start making sense. Payment mechanisms include fee-for-service as well as per member per month type payments. Beneficiary alignment, and this is really key, through prospective attribution. So we're actually going to talk about these are the patients in our program, and we're going to manage their health, and we're going to know who they are ahead of time, as opposed to doing it retrospectively. That becomes powerful, because if I know who my patients are, I can set up programs to keep them healthy, keep them out of the hospital, avoid unnecessary ambulatory sensitive admissions and emergency department visits. And so we build systems to do just that. And they're giving us rewards for investing in infrastructure and whatnot. So we got 21 institutions that are signing up for that. And they're coming in different flavors. 8 of them were pioneers in the early days of the ACO. 7 of them had MSSP arrangements before, and 6 are getting into this for the very first time. But I think we want to stay tuned to this because we'll be hearing more about it. I've alluded to this Medicare Advantage program many times already this afternoon. This is the chart, the solid gray line, illustrating we've gone from 13% of our Medicare patients in a Medicare Advantage program to 31% and projected to go to 40%. And what is this? Well, this is when the government says we can opt out of traditional Medicare. If you are a health plan, we will contract with you and pay you a per member per month fee. In Nashville, Tennessee, it's about $800 per member per month. And the HMO, its doctors and its hospitals will have the opportunity to design a population management system that suits them for the defined population, and we know who those patients are up front, and we can they can live on those dollars. Now it gets interesting, because if the patients are sicker, maybe we have a diabetic patient, ICD-9, I guess now 10, 250, there's an extra $250. So it's not $800, it's $1,050. If that same patient has peripheral neuropathy and they're diabetic, that's another $250 on top of the $250 for being diabetic. So now my payment, instead of being $800 per member per month, is $1,300. And if they have congestive heart failure to boot, that adds another chunk. And so we have patients in Medicare Advantage for whom the reimbursement could be $3,000 per patient per month. And this is important because it's driven by coding. And the ability to accurately code is going to determine the success or failure of the HMO enterprise. And guess what? We never asked our physicians to code at that level of specificity before. And for most HMOs that do Medicare Advantage, they have enjoyed the profits, but they've never enfranchised the doctors in a way that says, you know, if you code accurately and reimbursement improves, we're going to pass that down to you. That would be a progressive thought. And so here we are really beginning to figure this out. So I've got a whole section of my company that helps institutions optimize accurate coding for these risk arrangements, because it's a thing. And, you know, I don't know how many of you are interfacing directly with the Epic system, but it'll kill you, right? I mean, this is hard stuff. The analog to Epic, to me, is this new performance evaluation system. Did you get that new performance evaluation system where you got to do it online, and, you know, if you push a button, click, and if it's wrong, it kicks it back to you and all that? I mean, I'm thinking, now I understand what the doctors are going through. And so, again, a whole other group of people we've got focusing on how to help doctors get through this, to personalize the tools in order to make it work. But this is going to grow. The cool thing about Medicare Advantage, if you should decide that this is a business that you're going to be in, is instead of taking the rules as Medicare issues them, as I've described earlier this afternoon, you can really design the rules yourself, and you can do things that make sense. You know, when you're in Denmark and you're getting old and your knees hurt and you need a cane, you can walk into the HealthCare store and you can pick up a cane off the shelf and walk out and not have to pay for it. I mean, we're a little worried there's going to be a run on canes, but not really, you know. And so same thing in a Medicare Advantage plan. If it makes sense to get somebody an electric wheelchair so that they can not fall, then you can choose as an organization to invest in those kinds of expenditures regardless of what the rules in traditional Medicare are. And we've seen tremendous success not only in terms of keeping costs down, but improvements in quality and higher levels, dramatically higher levels of consumer satisfaction in plans like these that are well run. So as you can tell, I'm a fan. There's a lot of interest in Medicare Advantage from our member health systems across the country. About 70% of health systems in America are members of my organization, where they pay dues to have people a little bit smarter than I am present these fabulous slides, many of which I've stolen for today's purposes. But what do we like? We like greater control over the network. You know, we design the network. The opportunity to tailor the risk arrangements downstream with the hospitals and the doctors in a way that makes the most sense. Fewer patient identification issues because we know who the patients are, and we're going to manage to that. And we can determine the cost target as a part of the negotiations with the plan because we own the plan. And so we like that. If you're interested in the white paper referenced here, leave me your card at the end of the day, and we're happy to send that to you. So here's the summary slide of the smorgasbord of value-based care arrangements that the government is offering us, from pay for performance, which is where we've been, moving toward bundled payments and shared savings, shared risk, and on to full risk, such as in the Medicare Advantage program. Medicaid, is we believe turning to risk too, and we're seeing interesting experiments being done around the country. I had the opportunity to learn about some interesting work that you're doing to get outside the box with Medicaid. But I think we can pretty much count on that the road to success here is going to be based on innovations in how we take care of these patients who are less fortunate, maybe a little bit less compliant, maybe underinsured. I'll just take a moment to share with you a story about some work that we've been privileged to be involved in. I've got a chief medical officer, Dennis Weaver, who was asked by Johnson & Johnson to go into New Orleans post-Katrina and see if we can help. You know, how can we help? And so he floated around on a boat for a couple of weeks, and he came back to J&J, and he said, you know, what they need is a new delivery system for the uninsured and the underinsured, because Charity Hospital was the system, and it's 6 feet underwater, and the medical records are in paper, and they're in the basement. And so they got Levitt from the Bush administration, who had been recently embarrassed for responding slow to Katrina, the governor Blanco, and the mayor Nagin. They got him in a room, and they got a $100 million stimulus grant to open 99 new primary care access points, 37 of which became patient-centered medical homes, NCQA Level 3 certified, and they won the National Quality Award. The next thing we got was a phone call from the Adirondacks, a rural area south of Montreal, Canada, left of Burlington, Vermont, about the size of Connecticut. Industry's not good, commercial insurance not so hot, Medicare reimbursement for primary care physicians not great, hospitals starting to employ them, but they couldn't employ enough. 22% of primary care physicians in that community left in 1 year, 2008. That's a crisis for that rural community. They got together, Dennis and some lead docs and hospital executives. They convinced the legislature to give them a waiver, an antitrust waiver, that permitted all 7 insurance companies to sit around one table with Medicare and Medicaid and to design a patient-centered medical home program. We were able to get 226 providers and 50 practice sites and 36 different businesses, tax ID numbers, all certified NCQA Level 3 medical home on the 28th of February, 2010. and they launched a 5-year medical home project. All the payers, including Medicare and Medicaid, agreed to give $7 per member per month to the physicians. The physicians formed an organization, sent half the money into the practices to bolster practice economics and physician income, and half the money was used to hire pharmacists, social workers, and nurse educators in 3 pods throughout the region that became ambassadors to the patients from the physician's office. And, they run into a guy named Joe, who was in Medicaid, enrolled in Medicaid, had 6 admissions to the hospital the year before. Joe lived in a trailer. He had no phone. He had no internet. And he was diabetic. Ambulatory sensitive medical admissions, really unnecessary. But we were able to go find him. We had to go find him. We couldn't call him or email him. And once we did, he hasn't been back to the hospital. It's amazing what we've been able to do by just making sure that he's eating the right foods and getting exercise that he needs and, attending to his diabetes in an intelligent way, saving tons of money. So what's the result? 5 years later, here we are. Well, the total cost of care for the commercial population and the Medicare population is flat. No trend up at all over 5 years. And the Medicaid population, we're net negative cost of care. So we've actually reduced the cost of care in that community through these kinds of programs. And it's not, I don't want to say this too loudly because it would be giving away trade secrets. You're supposed to think this is, very complicated stuff. But you know what a big hit was? We figured out a way that when somebody's discharged from the hospital to get them an appointment with their primary care physician within 4 days every time. And when we did that, we saw dramatic reductions in readmissions. And so it's just sort of this day-to-day blocking and tackling of common sense things that you got to organize to do that we've never been paid to do before. But when we do, quality goes up, customer satisfaction, patient satisfaction goes up, doctors are more satisfied because they're really taking care of their patient's health and not just treating them when they're a catastrophe. Now, what about the employer side? Well, the thing looming on the employer side is we've got this Cadillac tax coming. Everybody heard about the Cadillac tax? The Cadillac tax is going to phase in from 18 to 2022 here. It's a 40% tax on employers who spend too much money on their health care. And we know there's a tax on employers, per the Roberts Court, if they don't choose to offer insurance, because Obamacare has that provision that if employers don't offer insurance, we're going to levy a tax. But the Cadillac tax is far and away a much higher tax. And so we believe that this is causing large employers to really take a hard look at what should their role be in health care for their employees in the go-forward situation. And we think that if the Cadillac tax remains, and they're talking about changing it, so politics will matter here, but if it remains, that a number of employers will simply turn the money over to their employees, pay the tax for not offering health care, and encourage their employees and dependents to buy insurance through the exchange. And when they do, that's going to drive us much closer even to a consumer era, because our consumers are going to be making decisions that in the past were really made by their employer. So reaction to this, we'll have some that will drop coverage, as I've described. We'll have some that will shift to the exchange, and we'll have some employers that will manage this proactively. We're talking to folks like United Health Group and other insurance companies who are looking at the exchanges for the employed population, and they're saying, this isn't so great, and we may get out of this business. And others at the same time are signing up. So this is sort of a frothy cauldron of evaluation and choice making going on between and among the health insurance providers that we've relied on in the past. This is, in my view, sort of the big deal here, and that is that no matter who gets elected for the next season of our life together, we're going to see and are seeing massive healthcare deductibles and deductibles that in many cases far exceed patients' net worth. In America, the average net worth, excluding the house, is below $2,000, and yet most folks are signing up for the bronze and silver plans with $3,000 and $5,000 deductibles. And so this is changing the dynamics. So if you get out of the catastrophic case, you're really now talking about buying, okay, I need an MRI, where am I going to get it? I need a CT scan, where am I going to get it? What do you charge for that? That's out of my pocket now. And so new dynamics of consumerism coming into play. And this is causing our thinking to evolve around what should our priorities be in the health system, and we are believing that we need to dramatically elevate the patient experience as a part of our calculus. The advisory board did surveys and found that 2/3 of consumers cite convenience as a top factor when they select a provider, that 88% say ease of getting an appointment is very important, and 40% will change doctors if they can't get a timely appointment. And then when they get the appointment and they show up in your garage and they find their way to the clinic, the experience that they have is something that they're going to evaluate with new eyes because it's their money. And so we're looking at this spectrum of everything that happens from the very first contact, which for many new millennials is not a phone call appointment, but an online appointment. Has anybody used Open Table to find a restaurant? Well, guess what? Those same people that use Open Table to find a restaurant want to use that to find a UTMB physician appointment. Do we have that? Is that something that we provide? That's going to be an important part of it. And then when they find their way to the office, when they arrive and are registered, all of these processes we need to examine in light of the fact that now the patient is paying out of their wallet. And when they see the provider, what does that look like? What does it feel like? What's the quality of the outcome? And what happens after they leave? Now, the employer community, folks like Boeing, are getting pretty aggressive on trying to keep costs down. Yes, they said we want a contract with a health system in Seattle that will take full responsibility for costs being flat or negative for for several years. And so they wanted the economics of all that, but they had a few little other provisions in their contract requirement. And this was bid out to the local health systems. Same day primary care appointment for acute conditions, 3 days for any condition, 10-day specialist appointment, extended hours of operations, weekends and evenings, extended urgent care hours, centralized phone number for triage, member website, phone apps. I mean, they're getting pretty sophisticated about what they're asking for, and they're choosing based on these criteria, and they're penalizing when they don't get it. And so here we are. Well, UTMB's got a little bit of advantage here because we're very integrated. But most of my members across the country are quite fragmented. I've just spent the last 2 years at UCLA, where they have 17 clinical departments, and each department runs their own clinics. I know there's some clinical department chairs here that would love to run their own clinics at UTMB, but let me tell you something, the patient experience at UCLA is not all that great, and when it's great here, but not there, and it's inconsistent. And so we're working with them to unify their patient experience through clinic operations. Operational complexity, we're big, complex places, multiple locations, and we got to get a lot done, especially in the academic medical center. And so how is it that we can take care of a complex patient without asking them to drive to Galveston and come into our crazy world, not just on Tuesday, but also maybe come back a week later for this, and a week later after that for this? Can we schedule it all at the same time? Those kinds of challenges are real and important. And then the ability to monitor how well are we delivering the service, and do we even know when we're falling down in terms of delivering a great experience? And we're political organizations in most cases. There's power, influence, and authority, and oftentimes the patient can be the last part of the conversation. So there's a lot here that's driving us to think in new and different ways. When you think about life as a health system, you tend to focus on the hospital and the hospital admission as sort of being what it's all about. But now UTMB and other institutions across the country are seeing that most interactions with patients are in the outpatient setting. A lot of them are even billing conversations. But we're touching patients. This is a typical health system here up on the board. 17,000 inpatient interactions per year in this example, 350,000 interactions in clinics, but 2.5 million interactions in email and phone and internet and all those other off-site ways. How's that going? What is that experience like? How is it for the patient? How is it for the family? And we've kind of broken the code a little bit on this and come to the conclusion that the answer to it is not necessarily to rush to the patient and the family and say we got to get that right, but first rush to our team, to you and everybody that works here, and be intentional about designing an experience for our team members and our physicians that will drive an outstanding patient or consumer experience. A lot of work is done by a lot of consulting firms around, how can we move the needle on the HCAHPS scores, the patient satisfaction scores. And sometimes a lot of money is expended and not a lot of needle gets moved, but even when it does, it doesn't really get at the root question, which is what is the lifelong loyalty of that patient to the institution, and how are we impacting that? And that comes from culture. That comes from how it is that we as a people interact with patients on a day-to-day basis. And so we're investing in getting to know and understand these issues so that we can positively impact the American healthcare system. Because using this example, again, a typical institution, not unlike UTMB, if you get your scores right and the various reimbursement mechanisms that underpin that, it may be worth up to $500,000. But a shift in loyalty of 10% of our patients to the good or to the bad is worth millions. In this case, 22 million in the example. And so it's really loyalty that we want to go after, not necessarily a higher patient satisfaction score, although I'll take that too. So how is it that we do it? Well, we got to take it apart and put it back together. And so we look at facility accessibility and design, the process and the blood and guts operations. How is it working? How are we using staff? How are we using nurses at the top of their license? How are we using doctors at the top of their license? And then are we using our information technology, this fabulous tool called Epic that costs us over $500 million here at UTMB? Are we using it to do all it can do? And then recognizing that out of this process, we're making change, and change just doesn't happen because we want it to. It has to be managed. Change management is a thing, leadership is a thing, and we got to pay attention to that part of it. And so we're having a lot of fun doing that work. We're looking at the success being driven on economics in two ways. The standalone physician enterprise, we want that investment to reduce. Most standalone physician enterprise in a health system environment loses money. I don't know how many of you know that, but that's the truth. And we know higher performing medical groups have higher revenue and the loss is less, the investment is less. But there's a connection. We know that when patients come into our clinics and see our faculty and even our residents, that there is a downstream impact in terms of services provided throughout the system that is measured on a completely different scale. As much as $30 million in this situation. And so people ask me, they say, John, you work with physician organizations at health systems across the country. How do you evaluate how we're doing? And we've got a dashboard with 100 measures. I've got a tool that I could show you that will knock your socks off. It'll tell you everything you want to know. We invented it. We designed it. I've got a picture on my wall at home of Hoover Dam, and there's a beaver talking to the deer at the bottom of the dam, and he said, I didn't exactly build it, but it's based on an idea of mine. And all that's very interesting. But what is the one number we might look to evaluate how we're doing? And we call it PEV, Physician Enterprise Value. And we look at the patients that we're seeing in the faculty clinics and in the community clinics. And what is the investment in those clinic operations? It's usually an investment And then we look at the contribution margin attributed to those same patients. And we've got a model for that. And we look at that relationship. And let's say it's 3.0. That would mean that for every dollar I invest in the physician enterprise, I'm going to see $3 in contribution margin. That's hospital, health system, inpatient and outpatient revenue, less expense for direct operations, but before overhead, contribution margin. $3 back in contribution margin. And you know what? When we see a ratio of 3 or less, we know that we probably have a turnaround on our hands, that there's dramatic improvements that can be made. If it's between 3 and 5, we know that there are improvements that can be made, but it's not a turnaround necessarily. And if it's 5 or more, we know we're doing pretty good. And we have lots of examples of that become exemplars for our work at places that are struggling. And so measuring this stuff is important because you want to look at the whole equation of everything we're doing. A lot of times what we'll have a tendency to do is to say, Chairman, you can't hire more doctors because, every time you hire a doctor, we lose money. Well, do we? Let's really know the answer to that question. Because we may be losing money over here, but there are downstream impacts over there. Let's look at the whole equation. And when we do, we may find that that doctor's losing money on both sides of the scale. And so, yeah, we got a problem. Let's deal with it. Or we may find, these physicians are actually accretive to the organization because on balance, there's 5 or more times the return on that investment. Let's maybe do a little bit more of that. Last thing I wanted to share with you is just a brief case study. We were invited to Cedars-Sinai, which is a strange and wonderful place. In many ways, like UTMB is a strange and wonderful place. Quite different, but still strange and wonderful. And they're a community-based hospital with 1,600 physicians on the medical staff. But they went out and decided to become a community-based academic medical center in spite of the fact that they had no university affiliation. Strange duck. They went out and spent a lot of money and hired rock star physicians from all over the country. And they've got 320 academic teaching faculty operating in 25 locations, all on the Cedars-Sinai campus, right there on, Gracie Drive, which is named after Gracie, the famous Hollywood actor. At any rate, they're there, and because the CEO, when he set all this up, had talked to his colleagues around the country, they told him one thing. They said, whatever you do, don't set up a practice plan. That's very dangerous. Now remember, at UTMB, I was one of the first executives of the faculty practice plan. And we've got Rex here. So they didn't do that because they were afraid of the notion that the doctors would get together and become a political force in the institution. And so they wanted to be totally integrated. So what they did is they gave the faculty practice to the chief nurse. And God, I love those nurses. They're really important. But this chief nurse in that hospital was armbanding patients as they were arriving for their clinic visits. They were having registered nurses at $150,000 a pop walk the patients into the exam room and ask them 21 questions before they'd be allowed to see the doctor. I mean, they kind of overdid it. And we were able to work through a process over about a 2-year period to streamline and standardize and improve the patient experience in it with these 25 clinic sites. And the year after we left, physician productivity went up 25%. And the year after that, it went up another 10%. And do you know what the average incremental value of a faculty visit at that institution is? It's $987.43 on average. And so the downstream impact and, the savings on nurses as we redeployed them in the hospital in different ways so they could be at the top of their license, we were able to affect what was a $30 million improvement. The year after we left, they had their best economic performance ever. And you know how they pay their doctors? Salary, no incentives for productivity. So there was tremendous power in this. UCLA heard about it, and they invited us over, and we had the chance to do it with them. Now, that's a different duck. UCLA, 2,000 providers, 149 practice locations, 100-mile stretch from one end to the other, long drives, 2-3-hour drive from one end of the market to the other. And so we had to figure out, how do we do this work at scale? And so we set up a patient experience enhancement team, 6 people. 2 practice management operations people, very skilled, 2 revenue cycle geeks, very important, the business of the visit, 1 clinician, and 1 IT expert, and we sicked them on 8 or 10 clinics at a site at a time over a cohort of 8 to 10 over about a 5-6 month period. And they would go in and do a deep dive, consult with the physicians and the staff about what their pain points were, point them to the standard that we had worked for 9 months to create, go for a go-live date, day 63. We are going live, we're making change, people's jobs are going to change, patient flow is going to change, we're going to move to the standard, and executing on that. And in the course of doing that, we invented this idea of the golden 15, these 15 things that need to go well in order for this project to generate the results that we need. Customer service things, branding things, because we're creating a brand. You know, what's it like to go to Starbucks? You all know. What's it like to go to a UCLA clinic? Well, it depends. We wanted to make it so we all would all know. Practice management and operations. That isn't good enough, obviously. You can't manage with 15 things. So we created 106 standards underneath of that to reinforce it. And then we went about the business of measuring how are we on the 106 and where do we need to go, and go through the change process, and here we are. And the downstream impacts we're matching up to to Cedars, the only difference being that their downstream number was a different number. It was more like $743 instead of $900. And it's interesting. I'll confide in you one change, because we made the change at Cedars with our own team and kind of muscled through it and handed it back to the institution. But at UCLA, they made the change, and we came and helped them. So it was more of an enablement concept. And they've kept going, and we're sort of on speed dial. They've backed off the 106 standards. They're focusing on 40 of them because they wanted to go faster, and they wanted to go faster on things that mattered. But this is transforming the patient experience in their clinics. It's improving the productivity of their faculty. We're finding all kinds of silly things that they're doing that are dragging the doctors down and the staff down, that when we fix, life is happier for patients, for doctors, for nurses. And so it's very rewarding work. Thank you all for listening to me. That's all I have to share with you today, and I'm happy to stay. If there are any questions, I think we've got a microphone. So in case I get the invitation to go to another place with a diverse audience like this of faculty, students, and staff, if you don't have any questions, give me some advice. What are the things you'd like to hear more about? What are the things you'd like to hear less about? What did I tell you you already knew and wasted your time? Any advice from the peanut gallery? It's your big chance.
I guess you could address how medical students now can plan for these upcoming changes.
Yeah. Well, first of all, I want to affirm your decision to pursue medicine. It is an essential profession, and America needs great doctors. The biggest thing I would encourage you on is to think about your role as a physician in the New World Order as a team sport, and not as an individual performance. Because I think my dad was a physician, Natasha's dad was a physician, and even in the early days, Dr. Weaver, my chief medical officer, they were trained to be the guy, to be the gal, to make the decisions. The patient's life is in my hands, and all that good stuff. And it was very individualistic. But to do what we're talking about here today, you're going to need a team. And you're going to need nurses, you're going to need pharmacists, you're going to need behavioral health people in order to organize a system to meet the demands of population health management. So that'd be my number one advice.
In implementing the changes that you recommended, what kinds of resistance to change did you encounter, and how does your team deal with that?
We didn't get any resistance. Can you believe that? Of course, we got massive resistance. And, you know, I think the dynamics were different at Cedars and UCLA in terms of how we set it up, because at Cedars, we had the CEO. This is very important. The CEO, top person, had to adopt this as their project. And so the CEO level support, we had that in both places. The CEO at Cedars said, we don't have the bandwidth to do this work, so we're going to bring Southwind and the advisory board in to do it. And so we had a lot of freedom to make change because of the license we were given. At UCLA, we're inheriting 17 clinical department chairs and their respective chief administrative officers, so there was a lot of work to get them on the same page, let alone them and us on the same page. And we underestimated that, I will tell you. One of the tactics that we deployed that I would think would be great advice for UTMB is we instituted a physician and administrator leadership academy. And we created a curriculum. It was a 2-year thing where we spend a day together once a quarter, homework assignments in between, related to the work. And so we were able to kind of bring people out of their jobs, talk to them in depth, people in leadership roles on the administrative and physician side, about the nature of the work and what it's going to take to be successful. And we brought our colleagues from the advisory board who were not part of the change management piece, but were sort of these, honest brokers of best practices around how it is that you make change in organizations that are complex. And so I found that extremely helpful to the culture redefining. For the folks that are doing the work, that are doing the change, it does require a morning, noon, and night attention to people and leaning into relationships and not taking anybody for granted. And to me, that's like cocaine. To be at an institution like this one and to be a part of making positive change, and the demand that requires of you to lean into people in every part of the entity to make it work is the drug. And, you've seen the movie Jerry Maguire, I love my life, I love my wife, I wish you my kind of happiness. I wish you that. That you could be addicted to positive change like a cocaine addict, and that would cause you to be expanded and you're leaning into relationships to make good stuff happen. It's mission work, really.
Hi. Thank you for your time, and I really enjoyed the presentation. I guess my question is two-part. I am employed in the TDCJ sector, so I guess my first question would be, how does this affect the correctional care population? And two, I'd like to share this with my nurse colleagues, and what do I tell them?
Well, first of all, TDCJ is amazing, right? You got this nice closed system where you've been able to build your organization. During the time I was here, the prison hospital management enterprise was remarkable in so many ways, and sort of different in kind to anything I had seen before. And so in many ways, it's kind of a privilege. I do wonder if we could figure out as a society how to extend the greatness of the prison healthcare system to prisoners when they get out, with the idea that we're going to make a path for them to stay healthy when they leave. And I think that to the extent that we can help them while they're in prison to be healthy when they get out, that would be a part of the population health management that we want to achieve versus just treating what's in front of us in terms of the sickness. My daughter is with Planting Justice, which is a not-for-profit in Oakland, California, and they're teaching prisoners urban farming. And when you teach urban farming, you're learning about nutrition, you're learning about vegetables, you're learning about fiber, you're learning about the gut, and they're doing all that. And then when the prisoners get out, they give them jobs for $17.50 an hour with health benefits, and they cultivate urban farms for relatively affluent San Franciscans and Oaklandians. And then for every 4 they sell, they do a free one in an underserved neighborhood or a food desert. And so, how can we take the cool things we're doing in TDCJ Health and extend it out like that? I think that would be really amazing. And in terms of the nurses, I would just love them. I mean, they're the essential part of the healthcare system, and we want to use them for what they were trained to do and not to do silly things. We respect them too much for that. Rooming patients, asking 21 questions of a patient who came in for a hangnail. You know, it's not why I became a nurse, right? So we need to honor them is the answer.
Oh, I think you, Eric Walzer, the chair of radiology. I really enjoyed your talk, John. Thank you for all these points you brought up.
Thank you for being here.
Well, I'm as one of the rock star physicians at UTMB, are there any other experiences from Cedars-Sinai that you think are applicable to the mission here at UTMB, having experience here as well?
Probably. It's hard to think about what that would be off the top of my head, but you know, the thing that I found about the Cedars faculty and the chairs in particular was that there was they didn't have a practice plan, but the institution was by its nature very entrepreneurial. And so a chair such as yourself in a Cedars-Sinai environment would be given a lot of freedom to explore entrepreneurial objectives in enhancing the institution's position in the academic world through teaching and research, as well as in the clinical world. And I think to the extent that we can create pathways of innovation and entrepreneurship among for our chairs, that's going to be a lot more fruitful than them playing the role of union steward. And so I'm not a big fan of the union steward as chair. I'm a big fan of the chair as CEO and entrepreneur of the enterprise, if that makes any sense. Yeah. Dave.
I was just curious, how are the innovations that are going to be bubbling up through precision medicine going to affect the economics of these somewhat Spartan delivery systems that we're moving toward?
So what do you mean by precision medicine?
So individualized medicine,
okay.
Probably very innovative, very individualized, probably very costly for many of them. Yeah. And how does that get rolled into, advancing healthcare in this kind of system? Does the economics support it?
Well, right now, precision medicine, as you describe it, is very expensive, and the price will need to come down. The theory of the case, of course, is that if you're a cancer patient presenting, and we can use precision medicine to know exactly what is going to cure you, that we can avoid unnecessary care and get a result better, faster, cheaper. And so it's going to be the balance of that working to our good that's going to accelerate precision medicine in the country. I do think that there are huge innovations, just to pivot off that, like the politicians do, the innovations around telemedicine care, a lot of care that can be delivered in different ways other than the office visit or the hospital admission, maybe hospital at home, using technology that will have a cost associated with it. But if we measure the cost of investing in that, it's going to be too high. If we measure the cost of taking care of a population and what, releasing them from the hospital a few days earlier, maybe admitting them directly from the ED to the hospital at home clinical model, and telemedicine with the specialists, for a remote area in Texas, all of those things, we can make sense out of it. But my big message, if you didn't hear it come through loudly today, is make sure you're measuring the right things, because we tend to focus on, we got to cut salaries because the budget's being cut. But what is the big picture economics? And we have a third of our people. I got 400 people that work for me. A third of them, over 100 of them, do nothing but the calculus around what does it mean if we take this initiative? What's the impact of ambulatory sensitive medical admissions and ED visits that go away? Those kinds of things, because you come to different answers. Yes.
Thank you very much, John.
Thank
we
you.
appreciate you being here today. A round of applause, please. Now that your hands are warmed up a bit, if you'll just reach down by your feet and pick up all your trash from lunch and put it in the garbage cans outside, that would be a perfect ending. Thank you.